area which have been developed for a couple of decades, which is routinely based on randomized control trial. And in this talk, I will briefly discuss the limitation of the classical randomized control trial-based subgroup analysis, and discuss the potential benefit of using EHR in analyzing subgroup, and the remaining challenging and what statistician can do to make this come true. Okay, so first a brief introduction of electronic health records. So electronic health records is a systematized collection of patients' medical history. So it contains very wealth information, and it is much easier to access, and it is usually contains a much larger study cohorts, and it can be multi-site study. So electronic health records has been applied to do the phenotyping, risk prediction, and causal link, and etc. So one of the classical problem about the causal link in drug development is called subgroup analysis. So subgroup analysis is the analysis of treatment effect within subpopulation. It is a very powerful tool in drug development. Why? Because a treatment may not be effective for the overall population, but it is often found that it might be effective for subpopulation. So how do we conduct subgroup analysis in practice? The gold standard practice is to evaluate the subgroup based on randomized clinical trial, and most of the existing clinical study, they do subgroup analysis in this way. However, this gold standard practice might come across some problem in practice. So here is one example. So this example is about the adverse effect of statins. So statins is a very widely prescribed drug in treating hypertension. And statin usage is potentially associated with the increased risk of type 2 diabetes for certain subpopulation. And there are many, many papers. And also researchers conduct many randomized control trials. But today, there is still no robust evidence. So why? Because the first reason is that in the randomized control trials, they have limited biomarkers. So you can only look into small number of candidate subgroup. So people might argue, okay, in this subgroup, you don't find any adverse effect, but for the others, what will happen? But you don't have such biomarkers. And the second reason is that in randomized control trial, it is very expensive. And recruiting the patient in randomized control trial can cost you a lot. And often the case that randomized control trial, it is power for the overall population. So in a subgroup, usually they don't have enough power. So if you don't find any adverse effect, the regulatory agency or the other researchers might ask, is it because you don't have enough power? And the third is about the generalizability of the randomized control trials. As we all know, the randomized control trial might not be representative to the real-world patient demographic information. So in this case, people might argue, even if you find some adverse effect, is it just can it be generalizable? Is it a trustworthy evidence? So with respect to all this limitation of using randomized control trial to analyze subgroups, a very natural idea is that can we use the EHR? Because we already mentioned that EHR will contain much wealth information, and you will have a much large study cohort. However, to answer this question, we need to take a closer look. So first, yes, using EHR have some advantage. First, in EHR, we can link the EHR with many different data sets, including the biobank. So we will have numerous biomarkers. And as we all know, if we want to define the subgroup, we need to have enough biomarker. And the more biomarker we have, the more subgroup we can look into, and the more evidence we can build about this heterogeneity. And the second is that, as we just mentioned, the subgroup in the EHR, usually we have much larger sample size, so we can address this high-cost problem in randomized control trial. And actually, if we just look into the randomized control trial, it would be very hard for us to get thousands of samples in any subgroup. However, with EHR, it is very easy for us to get enough sample to power our study. And the third is that the randomized control trial, it is a relatively small cohort. So in EHR, if we have enough EHR from multiple sites, it might be closer to the real-world patient demographic information. So it is a much larger cohort, so it can be used to address the problem. However, this is the potential benefit of the using subgroup analysis on EHR, conduct subgroup analysis on EHR, but there are still some remaining challenges. So these are some problems we need to address if we want to use EHR in analyzing subgroup. And we need to develop a proper statistical method to address this problem. The first problem is I just mentioned. One benefit of using EHR in subgroup analysis is that we have a lot of biomarkers, so we can look into many subgroups. And however, the EHR, although we have many biomarkers, however, the biomarker might be unstructured data. For example, it might be the physician's notes. And also, it might have many missing data problems. So for example, some of the patients, they don't have enough information. So how do you group those subjects? That would be an open question. And the second is that, as we all know, EHR is an observational data, and it contains high-dimensional covariates. So how do we estimate the subgroup effect accurately or in a scientific way? That's also a very challenging problem. And the third is that EHR might be stored in multiple sites, and the data might not be transferred publicly across different sites. So how do we conduct integrative analysis on subgroup? Because we probably need to follow some privacy constraint. And in the end, certainly there are some interplay between the classical subgroup problem and EHR. So for example, the subgroup selection bias and non-regularity. So non-regularity means that when the boundary of the subgroup is not smooth, then what will happen? Then the inference usually is very challenging. So if the EHR, for example, if we use some unstructured data, or if we have some missing data, then how do we define the non-regularity in this case will be also a challenging problem. So, and these are some open questions we need to address. Okay, so in 2022, together with Tianxi, we published a paper to propose a new data analysis pipeline to study the adverse effect statin based on EHR. And so the first 2 points are the potential advantage of using the EHR. The first is the wealth of information and easy accessible of EHR. So we can link the EHR with the partner health system biobank. So this will allow us to look into the genetic subgroup, which is often not feasible in randomized controlled trials. And second, in this EHR data, we can include 13,000 patients in total. So this can help us to achieve higher power in subgroup. And certainly these are two benefits, but as we mentioned, to make the subgroup analysis on EHR come true, we also need to address some problem and develop a proper statistical method. So the third point and fourth point are what we developed. The first one is about the missing data. So in this EHR data, it not only miss the some baseline covariate. Even the treatment variables, there are some missing data, and also the phenotyping, the outcome also has some missing data. So we need to use surrogate treatment variable and multi-model automated phenotyping to address this missing data problem. And in the end, this data is observational data, and the classical subgroup selection bias problem we also need to address in this high-dimensional observational data. So we develop a high-dimensional bootstrap collaboration method to address all these problems. And with that, we can have a more robust evidence about the adverse effect of statins. So in our paper, we claim that the adverse effect of statin usage for developing type 2 diabetes is marginal for the overall population, which means that, okay, it looks fine for the overall population. But we do find that taking statins significantly increasing the risk of developing type 2 diabetes for female patients with high genetic predisposition to type 2 diabetes. So that means for female patients with high baseline genetic risk to type 2 diabetes, we need to be more careful to prescribe statin, which is a very widely prescribed drug in treating hypertension. And we can see that all these findings might not be possible without using EHR data. First, the subgroup finally we look into is some kind of like genetic subgroup. So that's only possible when we link the EHR data with the partner health system data. And second, this data is large enough so we can power this study. Okay. Okay, so there are many other applications about using EHR data to look into subgroup. So for example, some people will use the EHR data to identify subgroup of high-risk veterans for future hospitalization or death. And that's really important because usually in randomized control trial, you only have some about your disease information. But about the high-risk veteran for future hospitalization or death, you also need to include some social economic information or the behavior information, which might not be stored in the randomized control trial. And also some researchers identify subgroup with heterogeneous treatment effect of DTG-containing therapies, and they use the EHR to power this study. And also, some researchers analyze subgroup risk of suicide. So this kind of study might not be feasible. This kind of prediction about the risk of suicide might not be feasible by running a randomized control trial. And we believe more will become in the future about using EHR to better understand the subgroups. Okay, so a brief summary. So first, the prevalence of EHR provide unique opportunity to better understand subgroup. Routinely, we are doing subgroup analysis based on randomized control trial. However, the randomized control trial have many limitations, including the low power, the generalizability, and also the limited biomarker, which will limit our looking into the subgroup. And the second is that although we have many potential benefit of using EHR data to analyze subgroup, there also exists some challenging because of the unique characteristic of EHR and its interplay with the subgroups. So to address this challenge and make the subgroup analysis on EHR come true, we need to develop a proper statistical method to utilize EHR in subgroup analysis. And in the end, we can see from our example, subgroup analysis on EHR can help facilitate evidence generation in drug development and regulatory decision making. So like the statin example, there is no robust evidence for many, many years, although there are many guesses it is potentially associated with type 2 diabetes. However, simply relying on randomized control trial, we cannot come up with robust evidence. But by using EHR, we have a better understanding about the adverse effect of statin. So in the end, what statistician can do by better utilizing EHR on subgroup analysis? So I think one suggestion or one lesson we learned from this research is that we need to look into some example existing for many, many years that the randomized control trial cannot address. And we should try to look into whether we can use EHR to better understand the problem and address the problem. Okay, thank you.
Do the same. We will switch speaker. At the same time, take questions.